Good evening, everybody. So today, I first welcome all of you on behalf of ISCCM Kolkata branch. Being the secretary of this Calcutta branch, I am Dr. Souren Panja. And as you know, earlier, about 1 month before, we started this COVID-related means different program, the first edition already that we conducted. But because there are so many webinars going on, that's why we just delayed this second edition. And actually, we are also trying to get some more information so that the webinar can be more fruitful, can be more informative. So today is the edition 2. What we have focused, our focus remains towards the care of the lung primarily. And obviously there will be the next another webinar will be on the tomorrow, and another webinar will be gradually we will announce. Tomorrow there will be that webinar will be focusing on the antiviral therapy as well as the plasma therapy, convalescent plasma therapy scope, and in India how it is progressing, and we will have a good faculties in that also. Today actually we are focusing in the pulmonary aspect. First we have our faculty. So there are 3 lectures. First faculty, Dr. Saurabh Majhi. He is a consultant pulmonologist, as well as he did his DM pulmonology from SGPGI Chandigarh. And he is excellent in this particular field. He will cover what are the scope of immune modulation therapy in the COVID-19 with severe pulmonary involvement or moderate to severe pulmonary involvement. And Dr. Saurabh Majhi is also one of the major key nodal person in Narayana RN Tagore Hospital, and he is looking after the different aspect of the COVID-related issues in the RN Tagore Hospital. So he has some experience in using different immunomodulator also. And the second lecture that will be covered by Dr. Sumit Ray. Dr. Sumit was a time when he was my senior colleague at Gangaram Hospital. He was vice chairman of Sir Gangaram Hospital Critical Care Unit, and he is also very learned. Not only learned, he has keen interest in particularly the ventilatory aspect, in different type of, you can say, what I can easily understand, or I feel that he is one of the father figure in different means ventilator or ventilator related issues. And whenever we had any doubt about anything related to ventilator, its mechanics, it's basically any ventilator related these difficulties, we used to actually discuss and talk to Dr. Sumit. He will cover the ventilatory aspect and its different ventilatory management in critical care, critically ill patient with COVID disease. And I think definitely it will be more informative, and more information is coming, and he is in touch with different faculties across inside the country as well as internationally with different faculties. So he must be a resourceful person, and he will highlight on this particular topic. And Dr. Suresh Ramasubban, which I think most of you must be knowing. Dr. Suresh is a senior consultant in Apollo Gleneagles Hospital, Kolkata. And he is basically primary specialty is pulmonologist as well as critical care medicine. So he will cover today the aspect will be more of the antibiotics. As you know, primarily COVID-19 disease is basically a viral disease, and after that sometimes some patient might require antibiotic, some patient may not get. And what are the evidence that antibiotics, is it the important that each and every patient with COVID disease with severe pneumonia needs antibiotics, or primarily it is the antibiotics which one we are overusing it? So what are the evidences in favor of it? How can we basically justify, as well as how can we basically use these antibiotics judicially? Because as you know, in the WHO has repeatedly given an alarm as well as alert that right now, because of the indiscriminate use of the antibiotics, there is very high level of resistance that is happening in last couple of months. So it may be that once we will be out of the COVID-19, but finally we will be landed with some era. I think it will be more of the pre-antibiotics era, when no antibiotics will work with this particular multi-drug or pan-drug resistant bugs. So this will be the covered, and after that whenever the discussion will go on, the audience might have some questions. So I will request all the audience to put their question in the, you can see on the if you are going through your, you have access through by using your laptop, on the right side you will get one chat box. So in that chat box, if you are aware of this platform, then no problem. Otherwise, in Webinar Jam, in this chat box, you can basically forward your question, queries, and you can also mention which particular basically faculty you want to hear from that faculty, or you want to have an open discussion. And then we can, that questions will be forwarded, and that we will take that question. That question will be then, whatever question we will get, if we get time, we will try to cover each and every aspect, and we will answer these questions from your learned faculty. They will answer it. And at the outset, I must thanks this HCB forum. So this is one forum. They are basically giving this web platform support. Not only that, for last 3 days, they have worked with the different aspects. They have first, then they have created this platform. They have already given all the, what I can say, all the mails communicated, as well as during the time what will be the design of this discussion. So all these areas they have covered it, and they are one of the pioneer in this aspect in Calcutta. Not only that, they are always in our help in the ISCCM Kolkata, and they are doing it without any what I can say, without any conflict of interest. So whatever we have wanted as a doctor, as well as part of the ISCCM Kolkata, they have done according to our wish and whatever requirement. So I must thank the ACP forum for giving us the support, as well as creating all these basically all this hard work hassle-free. So with this brief, I will request Dr. Saurabh Majhi to start the first lecture, and then Dr. Sumit, followed by Dr. Ramesh. And I will just request the audience, if there is whenever the lecture is going on, if possible, you please keep this audio mute, because otherwise there will be too much of ambient noise that can create or distract the speaker. So with this, I will request Dr. Saurabh Majhi to start the first lecture. And Dr. Majhi, please welcome. I think because there is little problem with Dr. Majhi's slide, so I will request Dr. Sumit to start the session. Then I think if Dr. Sumit is ready. Okay.
So, good evening, ladies and gentlemen. In the time of COVID, this is the new way to work, and I am always a little worried because of my lack of understanding of technology to do these things. But thank you so much, Jayati, for getting this right for me. So I'll be talking about management of acute respiratory failure in COVID-19, and I thank Panja for giving such a introducing me. Panja is probably one of the brightest intensivists that I know, and he said that they used to come to me for the ventilatory management, but we used to go to Panja for all other management whenever we were in doubt. So we used to go to Dr. Soren Panja for every other thing. So anyway, so I'll start off without much ado. All of you know the COVID-19 is caused by the SARS-CoV-2, which is basically uses the ACE receptors on the lungs to enter the body. And you know that billions of people have been infected, 500,000 deaths worldwide. India is also one of the top 4 countries in the world now, with more than 6.5 lakh cases and nearly 18,500 deaths. I won't go into that, but what is more relevant to us, quick look at the pathophysiology, which is relevant to our mechanical ventilating a patient of COVID, is that once the virus attaches to the sensors, ACE sensors on the lung parenchyma, the inflazomes are stimulated. There is an activation of the cellular and humoral innate immunity, etc., which basically leads to either a cytokine, cytokine release syndrome, a macrophage activating syndrome, but also very importantly an endothelial cell activation and a procoagulant state. All these leads to the pneumonitis, the ARDS, and the multi-organ failure that we see in severe and critical COVID patients. The important aspect of this slide is the role of hemostasis in this disorder, right? One is the inflammatory response which causes the ARDS-like syndrome, but also the hypercoagulability also causes, because of the macrothrombosis that it causes and the microthrombosis, leads to hypoxia by either embolism, embolic phenomena, or the microemboli or thrombi which forms, which causes significant VQ mismatch. And both these factors can cause the severe hypoxia that we see in severe COVID. And managing the two ends of the spectrum, the classical ARDS spectrum or the more VQ mismatch spectrum, because of the more embolic, thromboembolic phenomena, needs slightly different ways of managing them on the ventilator. So as those of you who are managing COVID would have noticed, that most of the patients who become serious, critically ill, start becoming serious about 7-8 days of illness, and a large percentage of them actually become critical after 10 days of the onset of symptoms. And the reasons for that are different. The initial phase is because of viremia. The second phase is more cytokine release post-viremia and the triggering of the cytokine response syndrome. So there's a beautiful cartoon by BMJ, the visual summary, as it says, of a patient who's requiring who would require respiratory support. The patient comes to you with respiratory distress with the symptoms of breathlessness, chest discomfort, anxiety, and all the signs of tachypnea, inability to complete sentences, accessory muscle use, etc., desaturation. And then you could have these patients mostly in type 1 respiratory failure. That is the commonest form of respiratory failure in COVID-19. But a subset of patients may have type 2, those who have a predisposition to it in the sense of having patients who are COPD, bronchial asthma associated with it, and also in patients who have such severe disease and have been fatigued by the effort they have needed to put in to improve their hypoxia, that they end up with retention of CO2 as they tire out and a hyperlacticemia. So the range of oxygen support that you could give is for mild to moderate disease. You could use a nasal cannula using it can give about 1 to 6 liters of flow in a nasal cannula. Your FiO2 can be anywhere between 24 to about 40%. It says 50 here, but actually, rarely can we give more than 40% depending on the flow that the patient's demand. Then you have the simple face mask, also called the Hudson mask, where you can use 5 to 10 liters, gives an FiO2 of anywhere between 30 to 50. Then you have the reservoir mask, which you can use where you are using higher flows, at least 10 to 15 liters of flow. The reservoir bag mask should be full when you are giving oxygen to the patient, provides higher FiO2s going up to 60 to 90% even. But be aware that giving low flows in that, less than 6-8 liters flow, could make the patient have some degree of rebreathing, and lower flow should not be used in reservoir bag mask. Then if in spite of these, if you find that the patient is not able to maintain oxygenation, then there are the options of nasal high flow oxygen or high flow nasal cannula, as it's called, HFNC, or the non-invasive ventilation that we can use, NIV, which could be either in the form of CPAP or a bi-level support. And we'll come to that in a little while. So if a patient comes to you with acute respiratory failure and early ARDS, not intubated, initiation of supplemental oxygen can be via the nasal cannula. Then you scale it up as the oxygen requirement goes. But if there are any signs of deterioration, then either a high flow nasal cannula could be used, or if the patient's efforts are significantly exaggerated and the patient is tiring out, then probably we need to use a non-invasive ventilation. There are issues about these two, and we'll talk about that. But remember that patients who are placed on non-invasive ventilation and high flow nasal cannula should be closely monitored, as the potential of deterioration in this is fairly quick. So observation actually required in these patients is sometimes much higher than those who are in the invasive on the invasive ventilators rather. So keeping a watch, just putting them on it is not going to help. You have to have intensive monitoring of these patients on HFNC or NIV. The role of HFNC and NIV has been extended in case of COVID, because what has been seen is there is a relatively higher mortality in patients who are intubated and ventilated. The data suggests that initially there was a lot of kind of data saying that almost 80% people die, those who are on invasive ventilation. That's not true. Where the real data has come in, long-term data has come in, particularly the NHS has a weekly update of data. The mortality from those who were put on ventilators was about 67% at the beginning of the pandemic there. But 6 weeks down the line, they learned how to ventilate these patients better. And if we do that, we would also be successful. And it was found that they could reduce the mortality 52% from 67% within 6 weeks. And if you are using HFNC or NIV, the worry is always there for aerosol generation and viral transmission. If we use a proper interface for NIV, a helmet would be perfect, but not available easily. But the mask fit, if it is good, then also it helps. And if everybody who's involved in the care wears PPE, it helps. It has been found that the aerosolization is up to about 40 centimeters from the patient, which is less than 1.5 feet. But yes, yeah, we have to be careful. You have to have negative pressures in the ICU that you have to reduce the aerosol staying in the air for long periods of time. NIV obviously is more useful than HFNC in the type 2 respiratory failure because it gives an inspiratory support, and in those patients who are starting to tire out, because the inspiratory support also helps in increasing the tidal volume and reduce the work of breathing along with the EPAP or the CPAP that the bilevel of NIV can give. But also remember that aerosolization is not just by NIV or by the HFNC. When you intubate a patient, you can cause a lot of aerosol generation and also probability of viral transmission, and one should be careful about it. And there are many methodologies of reducing that, and I don't have the time to talk about that, but that's probably another lecture. And those patients on HFNC could probably be given a mask on top of it, an N95, etc., mask on top of it to fit and at least reduce some of the aerosolization. The role of prone positioning, awake proning. Prone positioning has been part of our armamentarium in treating patients of ARDS for a long time on intubated ventilated patients, but awake proning with patients on high O2 flows or NIV is more recently used. It has been studied earlier, but more recently used with COVID. It's used as a rescue therapy before intubation. It may work. It's based more on perfusion redistribution rather than the shape matching theory or the sponge theory for the classical ARDS, which I'll talk about briefly a little later when I'm dealing with the classic ARDS cases in COVID. So the perfusion redistribution is what actually improves the oxygenation here. A little bit also of the sponge theory. We'll come to that a little later. And the benefits may be short-lived and can only be done in patients who can communicate and cooperate with you, who are able to turn and rotate and adjust position with your help. Okay, the position changes are every 30 minutes to 2 hours. Proning for intubated patients, as we all know, is slightly different. And this is the kind of the cartoon which shows how this can be done, and you can Google it and find it. It's all on the net, and it can be used. Very useful. We are finding it quite useful to keep patients off ventilation or even off non-invasive ventilation sometimes by using oxygen and proning, and that has been of great help. Now, if in spite of using high oxygen or NIV, patient still has persistent hypoxia or refractory hypoxemia, there may be a need for endotracheal intubation and invasive mechanical ventilation. So the possible clinical indications for endotracheal intubation could be an impending airway obstruction, signs of unsustainable work of breathing, refractory hypoxemia, hypercapnia or acidemia, the patient tiring out or has a secondary disease process of a COPD, bronchial asthma, which is making it worse, and encephalopathy, or the patient becoming drowsy because of either the cytotoxic storm or because his effort, the increasing effort and the hypoxia is making him more encephalopathic, or the possibility of inadequate airway protection. Not just that, additional considerations that we should have in patients of COVID is look at the disease trajectory. If the patient is rapidly deteriorating, even if he's able to maintain oxygen saturation on high oxygen, probably if he's deteriorating rapidly, best to intubate early, planned intubation in that case, because so that you can reduce aerosolization, etc. Because if it's a crash intubation, the chances of aerosolization and viral transmission is higher. So planning it in that setting is better, particularly in patients who have Possible endotracheal intubation difficulties anticipated. If the patient is hemodynamically unstable with hypoxemia while intubating, and also ask the question, if suppose you have to do a CT scan, etc. on the patient, will intubating and transporting the patient on a ventilator be safer than trying to take him or her on an NIV? And could intubating this patient reduce the chances of viral transmission? That should not be a priority, but can be a possibility. So among the indications, the specifics probably would be that your saturation is less than 90% despite maximal supplemental oxygen, rapid progression of disease, as I said, an arterial pH less than 7.3, PaCO2 more than 50 in a non-COPD patient, patients requiring more than 40 liters of oxygen on FNC, and an FiO2 of more than 0.6 and hemodynamic. If you have to intubate, the patient should be intubated by an experienced intubator. One should avoid bag mask ventilation if possible. If one has to perform it, inline bacterial and viral filter should be there. A 2% technique probably would improve the seal and reduce the leak. Once we have intubated the patient and ventilated the patient, then we have to ventilate the patient. Then according to Gattinoni et al., there are these two large subphenotypes of patients of COVID. One is the L phenotype, what he says, and the H phenotype. The L phenotype is those with low elastance, that means normal or high compliance. Low ventilation perfusion ratio, that means a high VQ mismatch because of the embolization and the microthrombi formation that I spoke about in this subset of patients. A low lung weight, that means not a boggy lung, not a classic ARDS lung. This is what the lung you see, this CT scan on the left side, the type 1. Low lung recruitability, when it's not a boggy lung, not a full-blown classic ARDS lung, the recruitability is low because these alveoli are open. The type H is the high elastance or low compliance lung, high right to left shunt, high lung weight, high lung recruitability, the classic ARDS lung that you see. So these are the two extreme phenotypes, I think, but in the real life, there is always a mixing. Studies have found, a Dutch study found that it is a spectrum. There are some patients who have what would clearly be only an L type, and some patients have a clearly H type, and most of the patients fall in between in a mix of these two types. So what do you need to look at when you are going to intubate and ventilate a patient? Before intubation, probably when you are giving supplemental oxygen by multiple mechanisms and awake proning, target the fact that the patient should not be having very forceful inspiratory effort. A forceful inspiratory effort and a negative pressure can cause what Gattinoni, Marini, and Brochard call as the PCILI, patient-induced lung injury. I kind of disagree with them on a little bit on that, and I'll come to that, the reason I'll come to that, and I'll explain what PCILI is and why I disagree a little bit on that. Other than that, that when you are ventilating the patient, then you have the two subphenotypes that we have, the type L, because the patients don't have the classical ARDS, the parenchyma is okay, it's the VQ mismatch, is the shunt, which is the problem. They require low PEEPs. The experience that I have of ventilating these patients is that we are not requiring more than 8 or so of PEEP, and sometimes even less. 8 to 10 PEEP is the usual. Use liberal tidal volumes. We are going up to a maximum of 8 ml per kg because the VQ mismatch is high. Sometimes the CO2 is also retained because of that. So you use slightly higher tidal volumes. Okay. Obviously, you try to reduce the oxygen demand, the respiratory effort, the work of breathing, and consider proning in this. In this situation, proning may or may not help. The whole function of proning in this is, again, as I said, the perfusion. It improves the perfusion relation part, right? Low tidal volumes are unnecessary in this, and high PEEP can be counterproductive by over distending the alveoli, which are of normal compliance. Most of the alveoli are of normal compliance, and actually it can cause more problems because increasing the PEEP could worsen the right heart pressures and worsen your oxygenation because of that. Then you have the H type, the classical PEEP, the classical ARDS, where you use higher PEEP going up to 15, 16. That has been rare. To tell you honestly, the only time I've used PEEP more than 15 in this whole pandemic of ventilating quite a few patients has been only one patient required that. Mostly a PEEP of 12, 14 in this subset, because I don't think it's a clear-cut edge type, but there's a mix of things going on there. So 14 is the maximum usual PEEP that I have used in this subset. Here we use a tidal volume of about 4 to 6 ml. I mean, our team does not go beyond 6 ml tidal volume in this subset. And also here, proning probably would be of much more benefit in this subset. This closely behaves and responds like typical ARDS. This is the subset you need to keep the fluid restricted. The volume restriction should be there. In the type L, that amount of volume restriction may not be necessary. The other important factor is ventilating. We'll come to that a little later about the classical ARDS, the weaning phase. Weaning is long in this. Don't be in a rush. Don't rush into weaning. They are taking a long time to get weaned. Make slow baby steps of weaning. Okay. And EPs trials should not be attempted, mostly positive pressure trials with pressure support and CPAP. Slowly, gently reduce the pressure support. Usually it is taking a fair amount of time to wean. Don't try to start the weaning process when the patient, a daily awakening with weaning trials probably should not be attempted in the severe hypoxemia cases. Only when the disease process is significantly settling down should you start that. Okay. And as I said, avoid abrupt changes. So what is the mechanism of PCLE or of injury from spontaneous breathing that they talk about? So one is increased lung perfusion, increasing distending pressure and increased tidal volumes, and patient ventilator asynchrony. This second two parts, probably this part happens primarily in patients who are on the ventilator and breathing spontaneously with ARDS. The reason why spontaneous in a mechanical breath, what happens in a positive pressure ventilation, if you are giving a positive airway pressure of about, say, 30 centimeters of water, the pleural pressure is usually about, suppose, 10 centimeters of water. The transpulmonary pressure is this minus this, which is about transpulmonary pressure is about 20 in this case. And the pulmonary capillary pressure is about 12. So the transvascular pressure is between 12 minus 10, which is about 2. And there is no interstitial edema happening in the mechanical breath. If the patient starts having exaggerated spontaneous effort, though your positive airway pressure that you have set on the ventilator remains at plus 30, but the pleural pressure becomes more negative, and the negative pressure is actually added to this. So your transpulmonary pressure actually increases, and also because of the negative pressure, there is an increased transvascular pressure, and this draws fluid into the interstitial compartment, into the alveoli, leading to worsening of the ARDS. This has primarily been defined for patients who are breathing vigorously, spontaneously on their ventilator. In a spontaneously breathing patient who is not on the ventilator, the ability of the patient to draw in fluid, you don't see that in acidotic patients who can generate large tidal volumes. You don't see that happening. And in a patient who is hypoxic and tachypnic, they don't have large tidal volumes. They don't generate large tidal. They usually have rapid, shallow breathing with fast rates and smaller tidal volumes. So PCD in a spontaneously breathing patient who is not on positive pressure support is probably not that likely. The patients on ventilator who breathe spontaneously with ARDS, they could be double triggering, reverse triggering, which all increase the tidal volume and entrainment. And thus in more severe ARDS, there are more chances that if you continue patients in ARDS, classical ARDS, continue patients on non-invasive ventilation or invasive ventilation without knocking them out in the initial phase, paralyzing them, the spontaneous breathing can cause the PCLE that Brochard and Magatinoni and Marini spoke about. Now the classical ARDS, what are the problems and concerns, which you have a smaller subset in the COVID patients, but basically, as most of the intensivists would know, there is the baby lung concept where you have normal alveoli and normally compliant lung, with a heterogeneous lung where there is volute trauma or over distension of the alveoli, which are the normal alveoli. Then high pressures, inspiratory pressures could cause the barotrauma. But what is probably missed out more is the atelic trauma or the shear stress, where the cyclical opening and closing of closed alveoli, right? So alveoli are closed, filled with with alveolar proteinaceous material, and they open from a completely closed position. There, the shear forces could reach 140 centimeters of water in spite of you controlling the airway pressures at 30 centimeters. So this is what is called atelectrauma, and the combination of these causes the release of more inflammatory mediators, further causing damage to the lung and biotrauma. And this is called villi, and that is the villi vortex, which has to be stopped, which is what Gattinoni and Merini speak about. And to remember, villi occurs at the two extremes, at the beginning of inspiration, atelectrauma, and upon reaching total lung capacity, there you can, at the end of inspiration, could be barotrauma and volutrauma. And lung protective ventilation should aim at preventing the stress and strain at both ends of the respiratory cycle. So what do you do? All of you know, for reducing volutrauma, small tidal volumes 4 to 6 ml in classical ARDS. Because you are giving small tidal volumes, you may need to increase the respiratory rate to about 30. Avoid barotrauma by limiting the plateau pressures to 30, the driving pressures to 14 or 15. If you can't do that in a volume control mode, probably you could try a pressure control mode or dual modes with inverse ratio ventilation. Increase the inspiratory time, so that the flow goes over a longer period of time, and and keeping the mean airway pressures high, to leading to longer inspiratory time, better mean airway pressures, better oxygenation. In a subset of patients, you could use recruitment maneuvers. Recruitment is the transiently increasing the transpulmonary pressure to open up closed non-compliant alveoli. To tell you honestly, in the whole COVID pandemic, I've used recruitment maneuvers only in that one patient where I used a PEEP of 16. Other than that, most patients have been scared of using, because most of them do not have the real classical ARDS that I have treated. Then once you have recruited the alveoli, then you have to titrate the PEEP to stop de-recruitment. The recruitment maneuvers are multiple. You can have 30 centimeters to 40 centimeters of CPAP for 30 to 40 seconds, pressure control breaths, and the maximal recruitment strategy and Farlap method are also there. I'm not going to go and define. Commonly, what I use is the first two, and limit the pressures. The maximal recruitment strategy and the staircase method has not shown to be beneficial in outcomes. Actually, it has shown increased mortality. Probably restricting the pressures to somewhere like 40 centimeters of water is good enough to recruit, if you have to do it. To stop de-recruitment, you titrate the PEEP. Either one can use decremental PEEP or incremental PEEP. In the classic ARDS, I used to use more decremental titration of PEEP, which was considered better because that would titrate it better and de-recruitment would be reduced. But in this pandemic, I'm using more incremental PEEP because I'm not sure at the beginning of hypoxia when I'm intubating which type it is, the L type or the S type or somewhere in between. If I start with a decremental PEEP of a high PEEP, I could cause barotrauma. So what I do is start with a low PEEP and go up by PEEP by 2 and look at the plateau pressure of the compliance. If the plateau pressure increases by more than 2, then we come back to the previous PEEP. If it increases by less than 2, then we keep increasing the PEEP. That's how we titrate the PEEP. It's important to titrate the PEEP. The ARDS-NET table probably will not work in this setting because you have severe hypoxemia without requirement of high PEEP, and that could be counterproductive using the ARDS-NET table. Role of proning, as I said, in the classical ARDS. So what happens quickly? I'll go through this in an ARDS patient in the supine position. These are the boggy alveolar lung proteinaceous material deposited here. These are the alveoli which are better functioning, and they tend to get over-distended. They get over-distended also because the chest wall is such. Anterior part of our chest wall are more compliant. Preferentially, the gas flows to this part and over-distends this lung. These collapse more and more. And the sponge theory is that, like a sponge, the wet sponge, this part is the boggy lungs. And also the perfusion is best here while the ventilation is best here. So the VQ mismatch is very high. When you prone the patient, what happens is these alveoli come here. They tend to close down a little bit, but not completely. The chest wall, which is the anterior chest wall, becomes posterior. It is against the bed. It does not allow the over distension now of the alveoli here. And these alveoli open up more because the proteinaceous material and the liquidy material, which is there in the boggy lungs, trickle down to this side, and these alveoli open up. So what is seen is that when you prone the patient, what it does is not open up the lungs more, but it makes it less inhomogeneous. It makes it less inhomogeneous, and then that is why the VQ mismatch is reduced and the oxygenation improves. So to summarize, in mild to moderate cases, oxygenation can be given by a nasal cannula or a simple mask. more oxygenation is required, then we give a reservoir mask or a high flow nasal cannula. The next step is CPAP or NIV. In a hypoxemic failure, that's the predominant type of failure. Along with that, use conscious proning. The reason we extend the oxygenation with these methodologies is the outcomes are not shown to be great when the patient is intubated and ventilated, but keep watchful expectancy that you may need to intubate. Do not delay intubation just because there are certain centers, I'm sorry to say, that are not intubating at all. If a patient needs intubation and ventilation and he doesn't get it, the mortality is 100%. If the patient needs intubation, ventilation, and he gets a ventilator, probably mortality is 50%. So remember that not ventilating a patient who requires a ventilator is out of question. After intubating type L, use lower PEEP, more tidal volume going up to 8 ml per kg, consider proning. These patients may require a little higher FiO2 because of the EQ mismatch. For the H type, higher PEEP, lower tidal volumes, prone positioning is very, very useful in this. And in weaning, don't make abrupt changes. Don't give spontaneous TP's breathing trials early. They are taking a long time to get weaned off. That's it. Thank you. Thank you so much.
Thank you, Dr. Sumit, for nicely explaining some of the aspects of the pathophysiology as well as as a consequence of that, the strategy of the ventilation of this type of patient. Because as we know, the one size never fits each and every patient. And the interesting fact about the COVID-19, till now we are not sure about what is the exact pathophysiology, and not only that, whether the same pathophysiology is operating in each and every patient, or it is for the each and every patient there is some different type of lung pathology that is happening. And he has very nicely explained about the different type of lung pathology, and there is overlap also, as well as the excellent explanation about the patient-induced spontaneous lung injury. That is a relatively newer concept, and earlier we were not having much idea about that. But after that COVID, we have clearly right now basically come to know what it is and how it damages the lungs. So it is our primary duty when to intubate and when not to intubate, and not only that, to prevent that, because this is another kind of the lung injury that we are allowing the patient to have that problem and patient is facing. So this is another type of what I can say an iatrogenic problem that is poorly recognized by us. So I thank you, Dr. Sumit, for excellent deliberation. And I will request if you have any questions, then I will just asking few questions to Dr. Sumit. And one thing, just I am asking Dr. Sumit whether you will be here to question till end, or you will
I'll be here.
Other
I'll learn.
Okay. So then I am just 2 or 3 questions. After that, we will go to the EA. Then together we can take the questions, and so that all the learned faculty, they can give answer, as well as I can say healthy discussion, as well as healthy sorting out of the some of the type of difficult to understand problem. So one question from Dr. Samudra Gupta, he has raised, that is phenotypically how to identify type OL and type H, to Dr. Sumit.
Right. Can you hear me?
Yeah.
Yeah. So see, that's as I said, it's not very easy to separate it out clear cut. So it's a spectrum. And so a patient who oxygenates well on high oxygen and does not have if this is pre-intubation, okay, has fairly good oxygenation without very high exaggerated effort, or an X-ray which does not show a florid bilateral kind of whiteout picture, are those who probably will fit into that. But those who do better with a non-invasive positive pressure, with a PEEP, whose oxygenation improves with PEEP, you have to try it out. Okay, those whose oxygenation improves more with PEEP or EPAP in an NIV are the ones who would tend towards the H type, and those who don't, who do better with just pure high oxygen, are the ones who are the L type. But most patients, I can guarantee you, fall somewhere in between.
And okay, then there is another question that has been asked by one of the very senior, not only senior, basically he is our, you can say, senior madam as well as professor, Dr. Amna Goswami. Madam was a teacher when we were students, as well as a professor in our different medical college as well as Calcutta University. So Madam has raised one question about the in the prone position, do you put pillow on to keep the abdomen free?
So, ma'am, so I'll answer the spontaneous first. Sorry, conscious proning, and for those on ventilator. So, conscious proning, you ask the patient to lie comfortably on their tummy. There's no need for a pillow under them. So, whatever is a comfortable position with a small pillow under their head, they can lie down, or a very small pillow under their head if they need a pillow, or if they can lie flat, well and good. But for patients who are ventilated, intubated and ventilated, they in some places so it's not necessary. So only in obese patients with a large pendulous abdomen, you may require to keep the abdominal pressure less, and in that setting you may put some pillows under the pelvis and the chest to lift the abdomen off the bed in that setting. But in a relatively leaner person, that we haven't found it necessary to do it.
Okay, thank you. There is another question, another our very senior faculty as well as our teacher, Madam Dr. Chumki Dotto. Madam has raised one question to Dr. Sumit. What is your opinion on hyperbaric O2 therapy in this type of patient?
Right. Hyperbaric oxygen therapy, high pressure. I mean, there is not much evidence for it, and in the setting of the only setting where it would be necessary probably would be the severe thrombosis of the pulmonary vessels, microembolization, and the VQ mismatch because of that. But even in that, probably high oxygen flow is what we are looking at with less PEEP. Not enough study. I mean, I am not a great of hyperbaric oxygen except in the settings of gas gangrene, etc. So I don't think it's something which is necessary. Actually, it is more important to correct the pathophysiology while oxygenating the patient, which is predominantly where we have found the severe hypoxemia, which is unresponsive to PEEP, is those who have severe thromboembolism of the multiple pulmonary vessels. They not be the large vessels, but small vessels. And probably using higher anticoagulation, and in some subset we have used thrombolysis also, segmental emboli, etc., which where we have used thrombolysis to open them up has been more useful. To tell you honestly, I don't have the experience, but I don't think it is going to be of great benefit to use hyperbaric oxygen therapy. Other faculty may comment on it. Paja, you may comment on it.
Okay. Just before there is another thing just related to this topic. I am asking on behalf of other audiences, that is,
right.
Is there any specific modes of ventilation that is helpful? That is one question that may
right.
have inside some of the audiences. And second one is any role of the nitric oxide in this particular group of the patient. These things, okay.
Yes. So one is ventilation modes. Actually, when we are intubating and paralyzing and ventilating, probably keeping it simple with the volume control mode. The phase when we are paralyzing is the best to go. Keeps it simple. I'm not saying that its pressure control is not good. If, as I said, if it's a classical ARDS type picture, if titrating PEEP, you're requiring high PEEP and you are not able to maintain oxygenation in that subset, going from volume control to pressure control and using inverse ratio may be of benefit. Okay. But in the ones where there is hypoxemia related to VQ mismatch because of the embolic phenomena that we see, thromboembolism that we see, there probably that is not going to be of benefit. Second, once we have the patient waking up and getting them off muscle relaxant, because of the hypoxemia, many of them have a high minute ventilation demand. Okay. And the catabolism. So the combination of these two things, and in that setting, sometimes pressure control ventilation, the patient coordination is much better and dysynchrony is much less. But having said that, you have to be much more watchful in a pressure control mode so that the tidal volumes don't go too high or too low. Many setups are not used to watching the tidal volume. I'm sorry to say, many, consistently. Mostly they look at the pressures. They don't look at the volumes that change when you are putting the patient on pressure control, and any rapid change in the compliance or etc. could change the tidal volume significantly, and which could be counterproductive. But I prefer putting the patient on pressure control when I am waking them up from muscle relaxation and sedation and trying to make them breathe somewhat on their own, I find them to be less dysynchronous. Does that answer your question, Paja?
Yeah. Okay. So any role of nitric oxide or not?
Oh yeah, sorry. Yeah, yes. Nitric oxide, yes, in those with a significant right heart failure, that subset of patients, PA pressures are high, PSP is high. You do an echocardiography, microembolizing, the thrombolysis may not work. You are giving heparin or low molecular weight heparin, and the PA pressures are high. In that subset, using nitric oxide may reduce the right heart failure and improve oxygenation. Will they in the long term improve outcome? Is difficult to say, because in ARDS studies, they have not shown to improve outcome. But what ARDS studies, classical ARDS studies, have also shown that almost 20 to 22% of patients have some degree of right heart failure in patients with ARDS who had no pre-existing right heart failure when being ventilated for ARDS. In that subset, yes, they could be useful.
Okay, thank you. Then there will be other question and answer that will be discussion will continue, because there are so many areas, other questions are coming. So before that, I will just I want to go to the another session by Dr. Saurabh Majhi. So Dr. Saurabh Majhi, as already we have discussed, he will cover the aspect of the immunomodulatory therapy in severe COVID-19 disease. So after that, there will be Dr. Suresh. So I think without wasting time, Dr. Saurabh Majhi, please you come and start your session.
Thank you, Chairperson, for the nice introduction. I am sorry that initially, due to some technical fault, I could not load my presentation. After the ventilatory strategy, which has been difficult, now it is come to the drug, and my topic for discussion is immunomodulator therapy in the COVID-19 with current evidence. As we all know, that is it's a large group of virus, that is the COVID-19, and which has been initial from the one city in the China in mid-December 2019. Now it has spread to the 214 countries and or territories in the worldwide. In 30th January, it was declared as a public health emergency of international concern, and now WHO has declared as a pandemic on 11th March. Now come to the pathogenesis. It is the SARS-CoV-2 virus with come to the pathogenesis. It is the spike protein, that is the S protein, which is bind to the ACE2 receptor of the pulmonary alveoli. And here the why the disease is so much, transmission is so rapid and so aggressive, because the binding capacity of the ACE2 receptor is 10 to 20 times higher than the other coronaviruses, which suggests that the SARS-CoV-2 might transmit more rapidly than from person to person. After the initial insult, then the body try to the first line defense, which is mainly from the interferon, type 1 interferon and natural killer cell, which take part in the combating the disease, and then come to the cytotoxic T cell, and after that the antibody producing B cell, which target the virus in the specific antigen. During this period of the virus and antiviral war, that is the body try to eliminate or try to relocate the virus in a single space or eliminate them. The patient with there is some release of the some inflammatory marker, and it has been observed that in case of the severe pneumonia patient, there is a substantially lower lymphocyte count and higher plasma concentration of the especially the inflammatory markers like IL-6 and the tumor necrosis factor. There is a decreased number of the CD4 and the CD8 T cell and natural killer cell also noticed in the severely ill patient compared to those with the mild symptom. That may be explained by the different hypotheses that probably there is some inflammatory mediated or virus mediated some bone marrow suppression or the local immune response that decrease the migration of the lymphocyte to the local area. The substantial reduction of the CD4 and the CD8 cell, which also peripheral in the peripheral blood, also noted. In the inflammatory cascade, there are different inflammatory markers which are produced, and it is very difficult to remember. That is the, but we will mainly concentrate regarding the interferon, regarding the TNF, IL-6, IL-1, and for which there are different drugs and which are helpful in the combating the disease. Now come to the antiviral immune response. This is the crucial to which occur mainly in the second week of the disease. That is antiviral immune response after second week of the after invading of the virus. This antiviral immune response has caused massive production of the inflammatory cytokines and damage to the host tissue. This overproduction of the cytokine, that which is known as the cytokine storm, which is similar to the SARS, MERS, and the COVID-19. And there is a phenomena, that is the secondary HLH, which is also seen in the secondary HLH, which is also seen in the COVID-19, which is occur mainly second week of the disease when the inflammatory markers are very high. Now come to the drug. There are list of the drug and which are used, and there are many drugs which are in the pipeline in the as a therapy of the immunomodulator in the SARS-CoV, and they mainly target the hyperacute immune response, that is the or severe immunoinflammatory syndrome or secondary HLH, and most of them, if I in the list, there is a initial stage from the day one we are using. There are many debates regarding the use of the chloroquine or hydroxychloroquine, and the mechanism of action I will discuss later. And the mechanism of action here, the mainly it bind with it block the ACE2 receptor and the change of the environment of the acidic, so that the pH change in the endosomal area, so that the virus multiplication is very prevented. And the second drug is glucocorticoid, which are used from the day one according to our guideline, but there are some debate and what is the current recommendation I will discuss. The other drug we can use the leflunomide, the thalidomide we can also use. Tocilizumab, there is a big name, now people are using it very much from the tocilizumab, and there are newer drug, that is the baricitinib, and there is a new guideline is coming regarding the new study is going on regarding the use of the convalescent plasma. Come to this is the pictorial diagram of the mechanism of action of the different drug, which can be, though it is in different stage of the after viral infection, that the viral entry, then the inflammatory marker release, and there is the stage of the drug which halt the progression of the disease in the different stage has been depicted in this picture. Now come to the first drug, that is the glucocorticoid, which we are quite familiar. It is widely used predominantly in the rheumatic diseases to control the autoimmune response. There are three mechanisms of action of the glucocorticoid. That is the direct effect with binding to the glucocorticoid receptor to glucocorticoid responsive element. That is the indirect effect, that is the NF-kappa beta, that is other transcription factor inhibition of the NF-kappa beta and activator protein 1. And there is the glucocorticoid receptor mediated effect, that is the second Mann-Schmidt pathway. The glucocorticoid use have been used in the different diseases in life-threatening conditions like sepsis in ERDS, and it has also rapid onset of action. The immunosuppression effect is also very rapid. It is frequently used in hyperinflammatory syndrome, and in the ERDS, according to the ERDS study, we know that the glucocorticoid treatment improved the oxygen saturation, it decreased the inflammatory marker, it decreased the ICU length and the ICU stay and ventilator periods, but the mortality benefit is quite doubtful. In a systemic review of the SARS treatment, that is the include in 29 study with the glucocorticoid use, the outcome is not very promising. In 25 studies, that is inconclusive with regard of the effect of the corticosteroid in the SARS, and the 4 of the study reported that glucocorticoid caused the possible harm. So, regarding the guideline, the WHO came first, that is with the caution of some basic principles should be followed with the using the corticosteroid in the severe SARS-CoV patient. That is, we have to weigh the risks and benefit while using the glucocorticoid, and the glucocorticoid should be used carefully and critically in patient with the SARS-CoV pneumonia. They have also mentioned that the patient with hypoxemia due to underlying disease and who has regularly used corticosteroid in the chronic disease further use the corticosteroid should be in caution. They have mentioned the dose. Regarding the dose, the low to moderate dose we can use, that is the 0.5 to 1 milligram per kg daily methylprednisolone or equivalent, and the duration should be short, that is the less than equal to 7 days. So, high dose or the pulse glucocorticoid is not recommended. But there are few observational studies. People have shown that the pulse methylprednisolone has some mortality benefit also. Though it is not a randomized control trial, it is observational study, and the study number is also very less. And came to the CDC also recommended that the corticosteroid not to be used routinely in patients with the COVID-19 for the treatment of the viral pneumonia, or unless there is other reason for the use of the glucocorticoid. Now come to the recovery trial, which is the published in the last month, the interim analysis, that is the mortality benefit is there. It shows that the death reduced the death by 1/3 in ventilated patient with the p-value of very much significant, and 1/5 mortality benefit reduced the mortality benefit of the 1/5, that is the other patient who are receiving the oxygen only. And they have also mentioned that there is no benefit among those patients who did not require the respiratory support. Based on the above result, we can prevent one death, can be prevented by using the dexamethasone around 8 ventilated patients and around 25 patients who requiring the oxygen alone. But Ministry of Health and Family Welfare, that is ICMR, also recommend the use of the methylprednisolone from the day 1 of their guideline, that is the IV methylprednisolone 0.5 to 1 milligram per kg, or dexamethasone, which has been added recently in their study, that is the 0.1 to 0.2 milligram per kg body weight for 3 days, preferably within the 48 hours. The steroid should be initiated within the 48 hours of the admission, or if the oxygen requirement is increasing, or if there is a inflammatory marker is on the rising trend. But the duration, regarding the duration, they have mentioned that duration should be 5 to 7 days, but the review of the duration of the administration as per clinical response. In the severe cases, the IV methylprednisolone 1 to 2 milligram per kg body weight, or dexamethasone 0.2 to 0.4 milligram per kg body weight for 5 to 7 days. Now come to the chloroquine or hydroxychloroquine. There is a large debate whether we have to use the chloroquine or hydroxychloroquine, or whether we have to use the hydroxychloroquine or not. That it is a very old drug. The rheumatology people are using this drug for quite a long time with a significant dose, and side effect is also very minimal. The chloroquine, it has some anti-COVID effect or some antiviral effect. It has also some immunoregulatory effect. There are many mechanisms of action that it inhibits the bind to the ACE2 receptor. It changes the pH of the local area so that the virus multiplication is prevented. The chloroquine and hydroxychloroquine were used in the COVID-19 from the initial stage according to we used it according to the ICMR guideline. So initially it was used also for the preventive therapy, and in the mild to moderate cases we can use till now. In a study, it has been shown that the hydroxychloroquine treatment for as short as 3 days has shown the accelerated virus clearance in patients with the COVID-19. And if we add azithromycin with it, then the clearance is more rapid and clearance is more persistent than the hydroxychloroquine alone. In the recent RCT has also showed that the chloroquine or hydroxychloroquine might improve the progression of the disease from the mild to moderate and decrease the progression from the to severe or the in a critical condition. But there are many studies has reported that either there is no benefit or there is harm in the effect after chloroquine or hydroxychloroquine treatment. So the according to the ICMR guideline, though it has been changed recently, that now they have told that the only mild and moderate case we can use the hydroxychloroquine, not in the severe one. In the mild cases, the hydroxychloroquine may be considered. In the high risk patient, that is the age more than 60 years, patient has hypertension, diabetes, chronic lung, kidney or liver disease, or cerebrovascular disease, or patient is obese. It should be done under strict medical supervision. In moderate cases, the dose is hydroxychloroquine 400 mg BD for 1 day, followed by 200 mg BD for 4 days after ECG assessment. In NIH guideline, they have clearly said that there is insufficient clinical data to recommend either or against the use of the chloroquine or hydroxychloroquine for the treatment of the COVID-19. The COVID-19 treatment guideline panel recommends against using the high dose of the chloroquine, that is 600 mg twice a day for 10 days. That is the NIH data. NIH has not recommend the use of the chloroquine or hydroxychloroquine as a treatment of the COVID-19. Now come to the another drug, that is tocilizumab. In the pathophysiology, we have seen that the IL-6 is the key inflammatory cytokine that has critical role in the cytokine storm and in elevated in the patient of the COVID-19. It is a recombinant humanized monoclonal antibody that binds the interleukin-6 receptor. It is the first drug for the treatment of the cytokine release syndrome, that is especially in the patient with the other comorbidities which are much prone to produce this cytokine storm. Now the mechanism, as I already mentioned, that is it binds to the membrane and the soluble form of the IL-6 receptor. Thereby, they inhibit the down regulation pathway, that is the JAK signal transducer, and activator of the transcription, that is the STAT signaling pathway, and stop the production of the downstream inflammatory molecule. There are many observational studies. I have quoted this study. This is the sample size is also not very much, but this is the study shows the beneficial effect of the tocilizumab. It is an observational study from the China, that is the tocilizumab treatment with the severe COVID-19. It improved the symptom improvement, the oxygen saturation, and lymphopenia in a few days. In this study, they have shown that this is the study population, that is the participant, there is 21 patient, and the age is mean age was 56 years. More of them are male, and comorbidities were also present, and the 81% were the severe disease, and there is also high flow oxygen 46%, in the invasive ventilation were 10% were present. Most of them are the severe disease, that is the 80%, and after using the tocilizumab, there is a change in the blood parameter. They have repeatedly monitored that after using the tocilizumab, day 1, day 2, and day 3, these blood parameter, that is here the important is as our own experience also is the same, that the CRP decreases rapidly. In this study, on the day 3, the CRP become more or less normal, but the procalcitonin is also normal, but the IL-6 here, the value of the IL-6 is increased after the use of the tocilizumab. There is a radiological improvement. In the upper one panel, there is a pre-tocilizumab, and the lower panel there is a CT scan of the post-tocilizumab patient, which shows the clearly radiological benefit after using the tocilizumab. And this is the left side, This is the benefit from the clinical parameter. The different clinical parameters are improved. Oxygenation and saturation all are improved, and in the mortality benefit, all the patients were there is no mortality in this group of the patient, and the mortality benefit is there. This is the outcome that the 20 discharge. They have also discharged all the patients, and most of them were the discharged less than 14 days, and there is only 2 patients who were discharged in the later. Now come to the another drug in the same group, that is sarilumab. It is also anti-human receptor monoclonal antibody launched for the mainly treatment of the rheumatoid arthritis. The mechanism of action is the same, that is that it binds to the IL-6, and there is some positive effect. There is some small study is going on there is positive effect in the severe manifestation where the IL-6 level is very high. Currently, there are many phase 2 and the phase 3 clinical trials are going on in the United States and the 5 European countries with this drug. This is the third drug of the same group, that is ciltuximab. It is the chimeric antibody of the monoclonal antibody bind to the IL-6, and that is approved by the FDA for the use of the Kesselman group. It binds both soluble and the membrane-bound IL-6 receptor given by the IV, and there are limited and unpublished data describing the efficacy of the ciltuximab in patients with the COVID-19. Now the recommendation, as per our recommendation, that is Ministry of ICMR recommendation, it is the off-label, may be considered. And the patient with the moderate disease with progressively increased, they have mentioned the term that they will progressively increase the oxygen requirement, and in mechanically ventilated patient not improving despite the use of the steroid. The long-term safety data in COVID-19 is largely unknown. A special consideration, that is that there is a chance of presence of raised inflammatory marker. We have to we have to monitor the inflammatory marker, whether they are raised in the form of the high CRP, interleukin 6, whether it is the 5 or 6 times elevated, people usually use it, and the ferritin level is also determined before using the tocilizumab. The patient should be carefully monitored in the post-tocilizumab for the secondary bacterial infection, and we have to exclude the active infection, and tuberculosis should be ruled out before use. The dose, ICMR has recommended the dose of the 8 mg per kg, that is maximum 800 mg at one time. It given slow IV with 100 ml NS over 1 hour, and if there is a clinical improvement, the dose can be repeated after 12 to 24 hours if there is a clinical improvement. This is the NIH guideline that interleukin 6, there is insufficient data to recommend either for or against the interleukin 6 inhibitor, that is all 3 drugs, that is sarilumab, ciltuximab and tocilizumab for the treatment of the COVID-19. Next. Now these are the newer drugs which are JAK2 kinase inhibitor, that is the baricitinib and luloxetinib. This is the small molecule compound. It acts mainly JAK1 and JAK2 kinase inhibitor. These drugs are mainly approved for rheumatoid arthritis and psoriatic arthritis, and in an open label clinical trial, that is well tolerated, and it is the mainly beneficial in case of the secondary HLH with the symptoms of the cytopenia, and other symptoms of the secondary HLH are improved though the study is very small and patient with the first week of this therapy. In the drug registry, in the trial registry, it has been shown that several trials have been registered for evaluating the efficacy of these 2 drugs in the treatment of the SARS-CoV, especially in case of the secondary HLH condition. Now come to the IVI. The high dose of the intravenous immunoglobulin exert the anti-inflammatory and the immunomodulating effect. Although the preliminary studies have shown that the IVIG in the treatment of the patient with the severe SARS-CoV infection related, that is in case of the influenza, but we need more clinical data for this use. There are few side effects of this. Currently, a randomized control trial is going on for this drug, that is IVIG, in the severe COVID infection, which has been initiated, and there is a doubtful, according to the doubtful effectiveness of the IVIG treatment in the SARS-CoV, and that there is a severe lung injury and the thrombosis. The IVIG option should be carefully analyzed before the using in the severe COVID-19 patient. That is the anti-IL-1, anakinra. This is also a new drug, though the drug is also used previously, but this is a new one in the COVID-19, in the therapy of the COVID-19. It is a recombinant and the slightly modified version of the human interleukin receptor antagonist protein. It is a naturally secreted, the interleukin naturally secreted from the monocyte and the tissue macrophage that selectively bind to the interleukin receptor and modulate its down-regulating activity. The blockade of the IL-1 leads to inhibition of the inflammatory response. In the phase 3 randomized trial with the IL-1 blockade, that is anakinra, in sepsis has shown the beneficial effect and with increased survival without increased adverse effect. Thus, considering this experience with the similar cytokine storm between the severe sepsis and the severe SARS-CoV, anakinra may play a role in the treatment of the severe and refractory cases. So, the pathogenesis, come to the conclusion, the pathogenesis is related to the COVID-19 is very similar. That is, there is a part that is some pulmonary vasculopathy and there is some inflammatory cascade. Both are going on simultaneously. The pulmonary vasculopathy can be managed by the antithrombotic or heparin and other modality of the treatment. And in case of the severe inflammatory response, that is the going on of the pathogenesis is similar that of the other disorder inducing the high inflammatory state. And there is a cytokine release, many cytokine release, but we are mainly targeting the IL-1, IL-2, IL-6 and the TNF alpha. A prothrombotic state is appear later, mainly both of these going on simultaneously. The drugs that are usually severe to treat the rheumatic or autoimmune disease, that is the immunomodulator, may play a major role in this setting where the inflammatory response is very high, which we will be more clear regarding their use and regarding their guideline if we get the relevant result of the relevant trial. Thank you for the patience here.
Okay, thank you, Dr. Saurabh, for excellent presentation. And this is really a relatively difficult topic, when to use and not to use. And I will just discuss these questions later on, because Dr. Suresh must be actually he was busy in taking the exam. And just after exam, because of my request, he just participated. And this is one, I think right now we are relatively ignorant about this disease, how to treat, or yes, still we are learning. And I think one of the key area is antibiotics, when to use, how to use, and we are rampantly use these antibiotics. I have discussed. And Dr. Suresh, I think he is one of the best person to highlight in this aspect, when to use or not. And I don't require further introduction about Dr. Suresh. Suresh is senior consultant in critical care as well as pulmonary medicine in our Apollo Gleneagles Hospital, Kolkata. Not only that, he has enough knowledge as well as the kind of experience in this particular field. And without wasting time, I will request Dr. Suresh, and then we will come to the question answer. You continue to send your question answer. And with this, please, Dr. Suresh, you start, carry on. And sorry for the year today.
Thanks, Soren, and it's a pleasure to be here, and wonderful listening to these speakers before. I think it's a good opportunity, as Soren is rightly saying, we're all learning. And mine is the easiest topic, evidence-based practice on antibiotic therapy in COVID-19. And unfortunately, there is no evidence for use of antibiotics. So I can finish the talk here right now saying that that's what it is. So let me just So it's going to be a very short talk, so it's not going to be very in detail that much. So if you look at epidemiology of antibiotic use in COVID-19, if you look at the Wuhan data, 58% of patients in Wuhan were started on antibiotics. However, if you look, this was the original study. If you now look at the recent papers from China which have come in, as well as all the patients who are critically ill, what you will find is that almost 100% of patients are treated with antibiotics. And anecdotally, many US and European physicians say the same thing. And there is no doubt that 100% of patients in Indian ICU receive antibiotics. And this is so because WHO and many other guidelines also are kind of recommend that we use antibiotics. So here antibiotics can of course have different meaning for different people. Some people will say, no, we are giving azithromycin as an antiviral agent. Some people will say doxycycline we are giving also has got some antiviral effect, and so on and so forth. But there is no data that any of these antibiotics, whether it's azithromycin, whether combined with hydroxychloroquine or alone, has any antiviral effect. So by definition, if you're using any of these, you're said to be receiving an antibiotics. And that's why I'm saying that 100% of patients in an Indian ICU will receive antibiotics. And in majority of the Western countries, it will be a significant number. As I said, 58% is a good ballpark number for all comers, and probably about 85 to 90% for all seriously ill patient, and about 100% for all critically ill patient would be the reason. And this is also a nice kind of interesting data. If you look at the first 9,000 reported cases of COVID-19 and you systematically review their what are they getting, the most frequently administered drug was actually after antivirals was antibiotics, and the antivirals in the first 10,000 in the first since January and February of this year would have been lopinavir, ritonavir, which is the commonest antivirals, and now it has probably fallen off the radar with remdesivir and taking over the mantle of the main antiviral. The antibiotics where again a majority of the patient got antibiotics in the first 10,000 patients, and this data continues to be like that, is that we will be giving antibiotics to our patient. So why is it? Why do we need to give antibiotics? What is the rationale for antibiotics? The rationale is very simple. The word that we are using is that you have the antibiotic is based on the experience with bacterial superinfection in influenza. As in the olden days, we used to call this as a double pneumonia. The double pneumonia used to be an influenza pneumonia followed by a secondary bacterial pneumonia. Now, the other concept is a co-infection. That means how sure you are that it is only a virus causing the X-ray abnormalities, or is it possible that the patient also has a strep pneumo and so on and so forth. So initially, if you look this rationale from both from the influenza era, you will find that with initial co-infection or secondary bacterial pneumonia happens in about 11 to 35% of cases in hospitalized patients, and they're mostly caused by strep pneumonia and Staph aureus. So the predominant feature would be to cover for CAP and community acquired non-methicillin resistant Staph aureus would be the automatic rationale for using antibiotics when somebody comes in or presents with a lower respiratory tract infection and has got patchy alveolar infiltrates on a chest X-ray and has got what is called as clinically we say that he is in stage 2, that is a pulmonary involvement, and rather than an upper respiratory or influenza like illness alone. So in the pulmonary illness phase of illness, when the patients present, we would be thinking that they might have a bacterial superinfection or a co-infection. Of course, the exact incidence of bacterial superinfection in COVID-19 is unknown. Though there are anecdotal reports of documented bacterial superinfections, the incidence seems to be much lower than that in severe influenza. If you note, the incidence of co-infection or secondary bacterial pneumonia remains at 11 to 35% with influenza. And if you're using markers such as procalcitonin, you will find that in fact a negative procalcitonin is almost always less than 0.5 to suggest that there is no secondary bacterial infection or a co-infection with a bacteria in this situation, which is causing systemic inflammation for sure. So the rationale for antibiotic is actually a little not very distinct. But the key rationale which everybody would advocate is that it is impossible to differentiate from CAP on initial presentation, because you have fever, cough, and breathlessness, you have a little low oxygen saturation, and you have patchy bilateral infiltrates on chest X-ray. And this is going to be any CAP, whether it is going to be strep pneumo or staph, it is impossible to say that. And it is impossible to be certain that there is no true infection. If you look at CAP data, about 35% of in CAP is actually virus, and the remaining are bacterial, and atypical is only 15%. And the presence of viral and bacterial, that is an adenovirus or a rhinovirus and a strep pneumo, is going to be a significant, almost a 30% to 40% overlap that happens in community acquired pneumonia. So you can never be certain about lack of co-infection, and this uncertainty especially plays on the minds of the clinician, especially when the patient is really ill. That means they are getting on to high amount of oxygen. We are not sure what is happening, whether it's only, as Sumit was saying, is it just the worsening of the alveolar damage that is happening, or is it new secondary infection, or a thromboembolism, or a heart failure due to myocarditis. It's impossible to say, and the easiest thing that for clinicians to do is to start antibiotics, because there is it is impossible to be certain about lack of co-infection, even when the procal is normal, because you will say, oh, procal is high only in sepsis. You can have local infection with a normal procal. So this is it. So if you look at the data and say, what is the true rates of super infection? And amongst the Italians have probably the best data on this. People who died with COVID-19, that is the subpopulation with the most severe disease, super infection were reported in 11% of cases. So if you're dying with COVID-19, you have to understand that almost 10% of patients have, 11% have COVID-19, have concomitant super infection with a bacteria, and they're dying not only from a COVID pneumonia, but they're also dying from a super infection. So it is going to be very difficult not to give antibiotics in this situation. If you look at the China data, which is published in this thing of 247 hospitalized patients, 15% of them, of these 247, and about 50% of these people who died actually acquire bacterial infection. So super infection is a big role. So this is where we have to distinguish co-infection and super infection. So can we prevent this super infection by giving them antibiotics? And the answer is no. But then can we monitor and see if they're getting new super infection? Probably yes. But unfortunately, the answer that most of us have is to give antibiotics in the earliest possible. So we need to have certain antibiotic prescription rules. That is the only way forward in this era, because I said when patients come in, it's going to be impossible not to give them antibiotics at that particular time because of the presence of fear of co-infection in a clinical picture, which is exactly that of CAP. Our question is that we know super infection can happen, but do we need to give antibiotics in the earlier stages to prevent the super infection? And therefore, we need certain antibiotic prescription rules, which is what I'm kind of trying to talk about. So the idea is that antibiotics, probably the best prescription rule is that probably we reserve prescription, not give antibiotics only in severe presentation. That means in patients whose respiratory rate is more than 24 per minute and whose SATs are less than 90% without oxygen. That's the definition, whether the ICMR or the WHO definition of a severe pneumonia. In mild to moderate disease, we get a lot of phone calls. We're doing a lot of telemedicine, and we see patients who have contact and who have young people who have fever, cough, and have a COVID positive, and we have a tendency to give them azithromycin or certain antibiotics, and there is no actual reason to prescribe antibiotics in this group of healthy patients or who are people who have mild to moderate disease and who are not requiring any oxygen therapy. So probably antibiotics in the initial phase to rule out co-infection with a strep pneumo or with an H influenza is to make sure that is only in those patients who have got high oxygen demands and rapidly progressing respiratory failure, or even just use the severe or life-threatening COVID-19 infection. You can use biomarkers, especially in the severe patients, and you might find that if the biomarkers like CRP and procal are decreasing or procal is normal, we may be able to withhold antibiotics. But again, there is no data in this group of subset of patients that we can withhold antibiotics safely without ruling out other infection. So patients without severe respiratory compromise should be managed without antibiotics, especially the mild to moderate cases. And of course, we are always, there are institutions which are doing a lot of CT thorax, and there are institutions which are not doing CT thorax. But And if a CT thorax is done, that is probably somehow going to be helpful in antibiotic prescription, because when you see a typical peripheral, subpleural, bilateral GGO, rather than a lobar pneumonia or a bronchopneumonia, you tend to probably use lesser amount of antibiotics in this thing. But as I said, because of the fear of co-infection, I think we should be using antibiotics, but only in the context of a severe COVID-19 infection or a life-threatening COVID infection, and that also again with certain rules which we are going to describe. So the rule is that if antibiotics are started, you should ideally obtain a microbiological testing. They may include urinary antigen test or the blood cultures, which should be done. So this has to be the balance with the potential availability of these tests, especially in our country where urinary antigen, and there's of course obviously a cost constraint also involved, because when we start treating patients, there is a limitation on what we can use and what we cannot use. And doing blood cultures in this situation, which is got a potentially very low yield, may not also be very advocated, especially when you're not having severe pneumonia. But in the presence of severe pneumonia, like the IDSA guidelines and the ATS guidelines for severe pneumonia, severe CAP, we should be sending 2 blood cultures. I believe certainly that we 100% should be doing it. Doing respiratory panel, comprehensive respiratory panels, which will cost another 18,000-20,000 rupees, may not be the best solution to this problem, but at least doing blood cultures in severe or life-threatening COVID-19 infections would be the best thing, and then starting a CAP-like regimen would be a better use of the antibiotics. Again, once you started antibiotics, we should be rapidly reevaluating, and if your next 3 days of a severe COVID infection, if the oxygen requirement is coming down, and you should be reevaluating antibiotic as soon as possibility. And especially if the low biomarkers of CRP is coming down and ProCan is at admission or at some point is normal, or a CT scan is not compatible and the blood cultures are negative, we should be stopping antibiotics at this particular point in time on day 3, rather than continuing them with them at a heavy for an extended period of time. If antibiotic treatment is to be continued even at beyond 3 days because the CRP is high and you are not sure, and if the patient's severe disease is stabilizing and is not worsening, I think an oral switch should be performed at day 7 and day 3 or 72 hours after initiation of therapy. And if the patient is able to take oral medication, and as I said, the absence of fever is not a criteria, since COVID-19 can have fever for 10 to 14 days. So there is not going to be a quick resolution of fever that you're going to have. So the key is to de-escalate if possible. If not possible to de-escalate, and a de-escalation from IV to PO should be done as a part of your antibiotic stewardship to do it. And even if you're not able to de-escalate for whatever reason, or to IV to PO also change is not possible, the maximum duration of treatment should not exceed 5 days for a CAP, as most of the recommendations are for 5 days in more for a CAP for a patient. Subsequently, if they have respiratory deterioration or their X-rays is not getting better, their oxygenation is not getting better, then appropriate investigation to find out if they are in failure, find out whether they have pulmonary thromboembolism, to find out if they have a superadded nosocomial pneumonia, or to find out if they have another source of infection or sepsis, is the priority, rather than to continue the initial antibiotics empirically beyond 5 days is not recommended. So I think one of the key things that we need to do is to stop antibiotics at there. And so what are we going to use? So if we are going to use antibiotics, it should be a CAP guideline. That means a beta-lactam which will provide coverage for strep pneumonia, plus a methicillin susceptible Staph aureus. So you can get away with an amoxiclav or a 3rd generation cephalosporin should be given and good enough. A once a day administration or continuous application of beta-lactam may be useful, because you don't have to go in again and again for the nurses. So what happens is in a lot of ICUs in the US and the West, where the nurses are taking care of other patients in a regular ICU, where one of the rooms has got a COVID patient and the other room has a normal patient. So every time they go in, they'll have to wear the PPEs. So to decrease the use of PPEs and to decrease the amount of time that a nurse goes in, so you can actually start a beta-lactam continuous infusion for 24 hours, and that may be useful in certain situations. But in our issues, where in our country, where we are having most of us are having a specific COVID units, and where our nurses are already there, I don't think wasting time on a continuous administration for for a suspected CAP is necessary. Again, macrolides and quinolone should be avoided because of their cardiac side effect. And as you rightly pointed out by Dr. Maji, we are also still continuing to use hydroxychloroquine, and lopinavir, ritonavir are still being used in a lot of institutions. And the ICMR still recommends hydroxychloroquine for moderate disease. So we should be careful about using the macrolides and quinolones and the hydroxychloroquine together for the QT prolonging effect that it can have. And obviously, because there are limited efficacy, you're going to have quinolone resistant bacteria and ESBL induction very, very soon in your ICU if you continue to do that. Whether do you require any atypical pneumonia coverage? You already have an atypical virus and you are covering the community acquired pneumonia. Do we need to cover like Mycoplasma and Legionella also in this situation? If it is considered necessary, so I would say that yes, you kind of think that this is a CAP and it could be a Mycoplasma or a strep pneumo H influenza and a COVID as a co-infection. So in that situation, the first 3 days of a severe or a life-threatening disease, adding doxycycline is probably the best way to do it about it. However, routine again does not seem to be warranted, because first of all, a low priority probability of co-infection with atypical pathogen is an issue here. As far as VAP is concerned, to measure just because people are saying that, oh, you have a patient with severe life-threatening COVID-19, he is on a ventilator, he will get a VAP, so why don't we give antibiotics? Which is probably not justifiable in any means, even before the era of COVID, and it's not justifiable in the era of COVID also. Again, once you get a VAP, yes, you need to treat a VAP according to your local antimicrobial antibiogram, and which would generally mean covering for an NDM-producing Klebsiella or a CRE secondary to Acinetobacter, which will require polymyxins and the immunocyclines and digicyclines and so on and so forth. So I think that I'm not going to leave as what is the VAP treatment. The VAP treatment and the diagnosis would be a separate topic, but there is no role for prophylactic antibiotics to prevent VAP. The other issue that happens for which antibiotics are given in the intensive care unit are called a secondary respiratory worsening. Like for instance, I just got a call from my unit saying that there is a patient who had come down on the FiO2 and was doing well on non-rebreather mask. He has come down to just 4 face mask, Hudson mask. He's back today again on non-rebreather mask. He had already received IL-6 treatment, and since he's immunosuppressed because of the cytokine, because of IL-6 blockade and concomitant steroid therapy, we should give antibiotics. And this is an issue which is true because the secondary respiratory worsening may be a new nosocomial pneumonia, new hospital pneumonia, acquired pneumonia, and especially in the presence of an immunosuppressed state with a dexamethasone or solumedrol in a low dose, plus a recent use of IL-6 blockade, you might not get the temperature spikes. You might already have a pre-existing leukocytosis. It is in this situation that it becomes very difficult to say, let's not go ahead and give it. But again, as I said, it will be prudent to go ahead and give it, but again, it's taking the same precautions that you keep your mind open, that there might be other causes, especially cardiogenic failure, pulmonary embolism, fluid overload, while you send cultures and get adequate respiratory sample. This is a time when probably using biofires and things, if cost is a concern, affordability and ability to get all these testings would be possible. But if nothing, then just sending 2 sets of blood cultures and sending a sputum sample out prior to escalating the antibiotics would be a very, very important issue. And this would be especially, but even in the absence of a treatment with corticosteroids and absence of treatment with IL-6 blockade, the worsening on day to 7 is probably a hyperinflammatory phase rather than an infection, and that may still be possible. Even in steroid treated and even in IL-6 treated patient, you will IL-6 receptor antibody and treated patient, you will still get a hyperinflammatory phase on day 7 to 9, and therefore it is possible that you might have to consider antibiotics. And again, the hyperinflammatory phase in the third day, that is from day 10 to 15, where you get into shock and other renal failure. Again, the presence of infection always is there in the back of mind. And I think drawing antibiotics and treating for regular nosocomial sepsis as a bloodstream infection is the best way to do antibiotics in this one. So I'm going to finish by saying co-infections in the time of admissions are always difficult. So it is all right to start a cap regimen for 5 days in a majority of our country, and to switch over to oral antibiotics on day 3 if they're getting better. And even if they're kind of hanging around, to do a 5-day course and no more. There is no role for antibiotics to prevent VAP or to prevent nosocomial pneumonia. In the patients who have gotten steroids, again, there is no role of giving prophylactic antibiotics to prevent it. And eventually antibiotics should be considered only as an empiric only in case of severe COVID-19 cases, and during the respiratory deterioration in patients who are already on treatment for COVID-19. So if this is what I would say is an appropriate or an antibiotic plan in the era of COVID-19. Thank you very much for your kind and patient hearing.
Thank you, Dr. Suresh. When there is no evidence, sometimes we can hear from eminent personalities as well as experienced personalities like Dr. Suresh to highlight this particular topic. And not only that, this is really a difficult task to find out whether this patient needs antibiotics or not. But one thing is clear from this talk, that any patient with severe COVID-19 is coming to the ICU or in the hospital should be treated with antibiotics. And about the regime and everything, he has clearly mentioned. But about the moderate disease, I think there should be some kind of judgment, as well as in later on when there is worsening, that should be there. So without, thank you, Dr. Suresh, for highlighting this topic. And I think there are at least some of the queries and different type of what I can say confusion has been cleared. And right now I am just again going to the question answer session. And there was some question that was being already has started coming on, and all the 3 faculties are there, so they can answer. So Dr. Oyan Banerjee has asked one question: is there any requirement of sending surveillance culture in moderate to severe disease who are supposed to receive tocilizumab or who are receiving tocilizumab?
Maybe. As I said, surveillance cultures, again, what all do you send? Do you send blood, respiratory, stool? What all do you do surveillance on? It's actually difficult to say. I think people who are receiving tocilizumab or high-dose steroids or steroids, because we're using only, I'd say, a low-dose steroid with the prednisone equivalent of less than 30, probably prudent enough to send 2 blood cultures every 72 hours. But that's what I do, but I'm not very sure there is any evidence. We have actually now reporting, in fact, what is more concerning is that you might even have a CMV recurrence. So what we are thinking, Dr. Todi and we were discussing this the other day, because one of our patients actually died from a CMV infection leading to severe aplastic anemia and disseminated CMV infection. So in fact, CMV antibodies is the one which I would be checking on if you're before you start IL-6 receptor blockade. So I think there are potentially a huge number of infections, and Pandora's box could be opened, especially if your patient doesn't significantly improve immediately, and you are giving somebody on a life-threatening disease on a ventilator and IL-6 tocilizumab, and then subsequently he remains in the fibroproliferative phase for many days, and then he is definitely going to get a lot of infections. But again, as I said, then again it is organ dysfunction scores that we should be following in this patient rather than surveillance culture. So if you have an increasing oxygen requirement, if you have an increase in hypernatremia, if you have a increase in low blood pressure, your liquid is high, you're requiring some low dose vasopressors, this is what I would say is an indication of infection in this. So serial soap and then sending pan culture according to the organ which is affected most would be a better rather than sending surveillance culture. My opinion, but I would let Sumit and Saurav also take the question.
So rather than this is Sumit. So surveillance culture, Suresh, so are you sending procalcitonin before you do the TOSI?
See, as a protocol, we are one of the things we are doing for all our severely ill patient is measuring CRP, procal, ferritin, D-dimer, LDH. So it is part of the procal is part of the package here. I understand with the cost concerns now coming in, the government coming in, it might get dropped off. It will get dropped off by tomorrow for sure. But as of now, able to get a baseline procal and say this is a baseline, but we will not repeat it just before we start a patient on tocilizumab. I don't think there's any reason to do it. And the other thing that we have noticed, if your IL-6 is more than 200, believe me, you also have a secondary bacterial infection. And if it's more than 2000 IL-6, you are in sepsis rather than in
absolutely.
Than you are in a COVID-19.
There is surely an infection associated with it. Yes.
So you can use the IL-6 itself as a biomarker for secondary co-infection. That's what I would say.
No, I mean,
so more than 10 times is okay to start tocilizumab. When it more than 25 to 50 times, beware that there is a secondary infection.
No, but probably combining. So you are doing a CRP, you're doing an IL-6 significantly high with a low procal, fairly strongly rules out a bacterial infection actually. Very strongly. So that is so we are using procal. We are not using, as you said, the price control is there. So we are not using procal regularly, but before tocilizumab, combining the IL-6, the CRP and the procal probably is helping us. I mean, it's not a perfect go, but probably.
Yes, CRP can also increase in the COVID also, but the procal rising CRP is bad prognostic marker in COVID. But the procal rising is also not usually seen in the COVID. So
yes.
raised procal and the raised CRP, probably there is some co-infection or there is an infection is there. The procal can be a good marker for whether de-escalating or the start of antibiotic. Procal can be a good marker.
So recently we had a patient on whom we sent a biofire because it's an MDS patient who had this thing, who had come in with COVID-19 positivity. And then we also found patient at H influenza. So there is a co-infection. So there is CAP needs to be treated in this situation. So there are certain patients when we do a little bit more. We have done a lot of serial biofire on VIP patients, MLAs and MPs, and we realize that in those patients when we do serial biofires, we have found nothing at all for many, even patients who have been treated on IL-6 antagonists. So we have some anecdotal experience with VIPs where we had no restriction on money. Where we were able to get these data out. But again, these are all anecdotal. They're not evidence.
Yes, Suresh, I mean, and Saurabh, Panja, all three of you, your experience about secondary infections in terms of VAP and HAIs has been my experience has been very, very low. I think that's because we are washing our hands to save our lives. So that's saving our patients from secondary infections. I mean, we never wash our hands as much and take care of ourselves so much that, when we are still touching the patient, probably secondary infection is also less.
We are getting a lot of enterococcus now because the stool cleaning is taking a lot of time.
What is it?
Enterococcus is a huge problem for us now. We had actually 2 VREs because the time it takes for the housekeeping to get in to clean the stool on the ventilator is actually a problem. So we are not getting that many Acinetobacter and Bacillus, I agree with you. But we're getting a lot of these skin bacteria and we're not cleaning them when the guys are going to do the procedure for a central line. So we're getting a lot of CRBSIs, but we're not getting any of the Acinetobacter and the MDR club in the respiratory secretions for sure. Because first, we are not suctioning them that much because they're mortally afraid.
Our experience. Our experience is also saying the secondary bacterial infection is much less in the this COVID area.
Actually,
probably due to the fear of they use the gloves more. Yes,
I fully agree with all of you because maybe
secondary respiratory infections are less in our COVID ICUs, but we are not seeing any decrease in the number of bloodstream infections that we are seeing in this group, especially as they are staying for when you have a bad ARDS. We have had several of these ARDS guys who got tracheostomized and everything. They all eventually didn't have Acinetobacter or Klebsiella in the lungs. It's always been the bloodstream infection either with a Candida or with an Enterococcus.
Okay. I think what we can understand maybe because if you look at the demography of these patients, most of our patients in the COVID area, their stay is relatively shorter. And second thing, not only that, there may be as you told, CRBSI, and sometimes it may happen because if we look at the infection control practices in the COVID areas, I think there may be some deficiencies as well as the surveillance. The way we used to look at the surveillance for any critical care patient, so that is relatively difficult because working with that environment is also sometimes there may be some deficiencies in the proper ideal infection control practice. That may be what used to happen. And I think because of the Acinetobacter may be low because sometimes what used to happen, our patient's stay is relatively shorter. Okay, so there is another good question for Dr. Samudra Gupta. So to Dr. Saurabh Majhi or all the faculties, is there any role of cytosorb in this prevention of the lung injury in this group of patients?
What is the question? The rituximab, use of rituximab?
No.
Cytosorb.
Any role of cytosorb or the cytokine removal, okay, in severe COVID lung disease?
Yes, there are some people are using, but this is not. I am not aware of the much use of the cytosorb in this COVID. Some people are there are the few study that is the 2 or 3% or 5%. This data are there, but the mortality benefit is not I have shown. That's why I have not mentioned in my lecture. But I don't know the experience of the other faculty here regarding the cytosorb.
Dr. Suresh, Dr. Sumit must be against cytosorb.
No. That's I would. You know what? This is. I was just going to say that probably I could have never thought that I would say this. That there is a potential probably role if there is a cytokine storm. This is a cytokine storm which is different from the cytokine storm of a bacterial sepsis, and that is the use of tocilizumab. Okay. If the principals agree on the fact that we can use tocilizumab in the cytokine storm, the problem with bacterial sepsis was the inflammatory removal of pro-inflammatory cytokines or its suppression was adding to a anti-inflammatory predominance and a severe secondary bacterial infection or the same infection worsening in bacterial sepsis. That we are not seeing as much in COVID because the cytokine storm probably is being triggered way late post viremia. So removal, I mean, if you see the cytokine storm mostly in the second week, the viremia is already over, right? Suresh, do you agree with that?
Yes.
And the removal of the cytokine at that time doesn't seem to precipitate as much a secondary infection, bacterial infection, as we saw in bacterial sepsis. So I would have never thought that I would say that there is possibility of, if you are using tocilizumab, there is a theoretical possibility of using cytosorb. Only thing is cytosorb is 4 times more expensive, or maybe 8 times more expensive, rather, two sessions.
FDA has given approval for
Yes.
use of this thing, but as you rightly said, it is more of a technicality and it's an easier way. So cytokines and chemokines both will be removed to a great extent. So it probably may be actually theoretically more beneficial. Than as compared to only an IL-6 blockade. So IL-1 receptor anakinra may be more better. So it's a lot of this thing, but removing the entire cytokine package and entire chemokine package. So it is as Sumit is saying, it is about the CARS and the SARS. I think right now it is a classical 3-phase disease. You have an influenza-like illness, and then you have a pulmonary phase, and then you have a hyperinflammatory phase. So what we are trying to do is to prevent the hyperinflammatory phase, which is the ARDS and the shock and the renal failure. And to do that, you want to remove the cytokines. And then because the IL-6 levels are very easily trackable here, and there is no, as I said, so it will be. I agree with Sumit that this is one of those instances where we might be saying it is. I think technically just difficult to do it, and the cost effectiveness is not there. No experience, but I have to say no experience.
Yes.
Okay. I think in the coming week, Thursday, there is another session that we will conduct, that is on the extracorporeal therapy scope in COVID disease. So ECMO, extracorporeal, means cytosorb or cytokine removal, that will be discussed in details in that day.
I think Calvin has been doing a lot of good work on ECMO. I think this one of the things that has happened really is that Emory, Shashwati and their team, as well as Medica, Anirban and everybody, they've been doing a wonderful job of doing ECMOs. So I think it will be looking at, and I think probably Aviral and all those guys in Medica.
Orpon and all that. So there is another question. So that Dr. Sasikant, just a moment, Sahis Kamath, he has raised one question about what is the role of plasmapheresis in severe COVID-19 disease pneumonia. Role of plasmapheresis in severe COVID-19 pneumonia.
I think part of your extracorporeal treatment next week. Because I think so. When I was in 1998, when I joined this thing US, and before the Zygris was even invented. So plasma exchange was touted as the #1 treatment for sepsis. All right. So when I joined my first year of residency, this was considered as the number one thing. All right, but then Zygris started making its appearance in 2000, and this kind of died. There are a few people who still believe that therapeutic plasma exchange might be a great option for treatment. I'm not one of those believers, but yes, it is a big group of people. It's like the if you believe in the school of Scientology kind of a thing. If you believe in it, you believe in it. So.
Acha. Another question is from in the coming week we will definitely go all these details, and Dr. Sakko Mojumdar from NH Tagore Hospital has raised one question. What is the standpoint of the panelist regarding the use of lopinavir and ritonavir after WHO has removed this the arm of the therapeutic trial in the recovery trial? So, what is your right now the standpoint about the lopinavir ritonavir when it is in the ICMR guidelines, but WHO has removed that arm of the continuing that therapy in the recovery trial?
I think if I'm not wrong, lopinavir ritonavir has been removed from the ICMR also, the latest one.
Okay.
Yeah, I mean, even before that, I had never used it, and I didn't think that this antiretroviral would be of great benefit. Even remdesivir, the studies show only shortening of length of stay, and you have to. It's the phase of the disease where you use it, and I mean, I would ask the others, Soren, Suresh, and Saurabh, that I mean, are you facing difficulties in treating the patient in the phase of viremia? I think they're getting sicker post viremia, isn't it?
Yeah.
So, I mean, which phase do we use the remdesivir? Actually, if we have to use it, it would be probably we have to start it on the 7th, 8th day of the illness, and that is the
Pulmonary phase.
Yeah.
Yeah. So, as I said, the second phase is the pulmonary phase. That means they have the alveoli are getting infected with the with these virus.
Exactly.
When they are in the ARDS, which is the hyperinflammatory.
Exactly. So
pulmonary, that means they're starting to require more and more of oxygen. That's when you probably want to use
absolutely.
convalescent plasma, remdesivir, whatever you want to do. Remarkable.
So I think in nutshell, maybe on the say 6th, 7th day to 8th, 9th day means maybe the window maybe on the say around 7 day or 8 days maybe best what I can understand.
Yeah, with a worsening at that period, yes.
That is the time. So because sometimes to get that timing is also very difficult. So the time when the patient is having gradual worsening of the respiratory function, I think that is the time in the early phase you should start it. And so there is another question from Dr. Somudro Gupta, that is infection control practices with ventilation requiring patient. Just a moment. Any role of any dedicated ventilator uses for those patients, and procal and lactate guided antibiotics uses along with sepsis bundle. Dr. Samudro, I could not exactly.
Two different questions, I think.
Dr. Samudro, if you can hear me, can you just raise your question from your own voice? You just switch on your audio and then please raise your question. Dr. Samudro, please. I think he has raised that question, then must be leaving, because the question was being put 15 minutes before. Right. And Dr. Tapon Sarkar, when antibiotics should be started, or that we have already. Okay, anyway, Dr. Suresh, once you explain, Dr. Tapon Sarkar has asked one question: when the antibiotics should be started? If
anybody who presents with severe COVID-19 infection, that means requiring high amount of oxygen, not in mild and moderate disease, only in severe and COVID-19 and pneumonia. So to treat a co-infection with a CAP with other organisms, we should be doing treatment with CAP for 5 days with and trying to get them into with the ceftriaxone plus doxycycline.
Okay, so there is no new question. I think we have also we have crossed the time limit also, and there was almost good participation. Approximately 59 was total participation, maybe because it was getting lengthier, so some left. So tomorrow, thank you all the faculty, Dr. Maji, Dr. Sumit Ray, Dr. Suresh, for kindly be here and giving your talk as well as sharing your experience. So before you will just want to announce that tomorrow evening there will be another session that is basically targeting antiviral therapy, evidence-based practice, what are the current evidences that we should practice, and another is the convalescent plasma therapy. So the speaker is Dr. Binod Singh from Sir Gangaram Hospital, Delhi. As we know that in Delhi they are using lot of convalescent plasma. So that's why in Calcutta we are relatively, I think, little behind the Delhi or maybe Mumbai. So that's why I have kept this lecture, and it is not a very difficult task, because if really it is helpful, then how to do it, and it is not only blood bank is necessary. Along with that, the mindset is, I think, is necessary to treat this. Some of the patient may get benefit from that. So tomorrow 5:30 that will be there, and please join that. And before that, I want to make another announcement. By in next 24 hours, all the audience, you will get one email from this your ACP forum, actually to know the quality of the lecture, as well as to find out if there is anything that we can improve in our ISCCM Kolkata branch that will help us to improve our quality of lecture as well as the deliberation. And if there is any new suggestion that you can put, not only in the COVID area, but even beyond COVID, we have to cross that COVID. So there are other issues also, so that we can basically get back from you. So with this, I will thank you all the faculties and also all the audience to be here to share, as well as you put on all the questions answer. So with this, I will, on behalf of ISCCM Kolkata branch, I say call it a day, and hope that tomorrow, if you have fine time, please join us for the lecture, as well as in the coming Thursday, there will be the session 4 of that will be mainly focusing on the extracorporeal aspect of the COVID-19 disease. So ECMO, as well as cytokine removal therapy, as well as I will also try to keep one lecture where there are some specific situations, particularly renal transplant patient or immune suppression patient getting so many drugs. So once they are getting COVID infection, so is there any need for the drug or dose or the drug modification or not? That is also important. So with this, thank you all.
Sir,
Yeah,
one more
okay.
thing.
Please.
One more thing.
Yeah.
We all who have registered and who have viewed this whole webinar will be getting an email to view the recorded version once again.
Yeah.
So
Okay.
yes, please check the recorded version, and you can you can always review and revisit us in this recorded version. Thank you.
Thank you.
Okay. Thank you.
Thank you.
Thank you.
Thank you.
Thank you everyone for joining.